This conference will now be recorded.
Okay, we can start.
Okay. Hello, I'm Jeannie, the ST5, taking the Part 3 examination today. I've gone to the scenario and ready for the structured discussion.
Okay, so given this scenario, can you tell me what history would you like to gather from her, from the patient?
Yes, so this is a patient of perimenopausal bleeding, 52-year-old lady. So I would first take a history of the onset, duration, and progress of symptoms, since when she's been having the bleeding and what is the bleeding pattern, and the duration of the bleeding, the flow, and any pain associated with it, and uh, then associated symptoms like any weakness, like signs and symptoms of anemia or any bowel bladder complaints, and what medications she's been prescribed, tranexamic acid, any other medication, over the counter medicine she's been given. And then I would like to take her medical history, if she suffers from any other medical problem, surgical history as well, any other medications, any family history of concern, like any cancers of the uterus, or any family history of cancer. Then her smear history, detailed smears. Is she up to date with her smears? And any her obstetric history. What is her pregnancies, mode of deliveries, any complications, and any form of contraception she's taking, or if she has any other or a hormone replacement therapy, if she has any menopausal perimenopausal symptoms like hot flushes and other mood swings, etc. So, and mm, then allergies, and blood group, BMI, addictions, mental health history, and um, uh, partner support, and BMI, blood group, and reservation for blood transfusion. So, and what test she's been advised apart from the scan, and whether she's got any blood test done, like a CBC, or any other test done. Um, mm, yes, these are the history I would like to take from this patient.
Okay, so patient has cycles every 2 to 3 months, followed by heavy bleeding for 15 days, and this has lasted for a year. What do you think could be the possible diagnosis, and how are you going to investigate her further?
The possible differential diagnosis for me would be, first of all, is um, um, abnormal uterine bleeding due to endometrial hyperplasia, and it can be because the endometrium here shows 16 thickness, and or it can be an endometrial polyp as well, or it can be endometrial hyperplasia, can be or it can be a sinister, like it can be endometrial CA as cancer as well, um, or it can be secondary to some drug-induced endometrial hyperplasia as well. Uh, yes, that is what I can think of. And so further investigations, I would first I would need to examine her in the presence of a chaperone, with her consent. Her general investigations, pallor, I would check her pallor and blood pressure as well, and check her abdomen, and then a per speculum examination to look for any local abnormalities, the cervix, and the per vaginal examination, the uterus size, and any masses, and then after that I would she's already got a scan done. I would I would confirm that this was a so this is a trans-abdominal ultrasound. So I would maybe advise a rescan, transvaginal ultrasound, which has a better resolution, and then I would go for advise her hysteroscopy, a diagnostic hysteroscopy, and biopsy for this patient.
All right. So a diagnostic hysteroscopy and a transvaginal scan was done. Here is the
Hmm.
report. How will you go about managing her?
So she's a patient of atypical endometrial hyperplasia. So this patient, I would offer her counseling and then the management. Atypical endometrial hyperplasia, I would explain to her the risks of progression of to endometrial cancer uh, is about 25%. So, so that is the explaining to her about the risks. So, advice offer her hysterectomy, and it can be laparoscopic or an total abdominal hysterectomy. Um, so, laparotomy. So that depends on the expertise, and so that would be the definitive treatment in this patient. Uh, Otherwise, and depending on the patient's wishes, if she I would then counsel her, and if she yes, the definitive treatment would be hysterectomy for this patient. Yeah.
Okay. Is there anything else you would like to add?
Yeah, and hysterectomy along with the bilateral salpingo-oophorectomy would be the definitive treatment for this patient.
Mhm. Okay, that was the last question. If you would like to add something, you can add.
So I would this patient then I would give her all the written information, document this, and take her wishes, take her consent, and with respecting her wishes, and inform my consultant, and give her information leaflets, and then write back to the GP for this.
Okay. All
Uh,
right.
if she wishes for to preserve her uterus, then that would explaining to her the risks of progression to cancer and complications. She can be offered hormonal treatment like a Mirena or progesterones or oral progesterones as well, and then a regular follow-up. She would need to go for regular follow-up and need for an repeat endometrial biopsy after 6 months, every 6 monthly. Uh, Actually, I've forgotten follow-up.
It's okay. Okay, I think I'll pause your time now. There's
Okay.
some 30 seconds remaining. All right. Fine. So, any reflection from your end?
Uh, yeah, the conservative management, if respecting her wishes, what she wants. If she wants conservative management, then the medical management need to have discussed earlier, and the follow-up, regular follow-up. Uh, that
Okay.
That I missed, yeah. And,
All right. Fine. Well, so first, let's just go through the question once again. So this is basically a structured discussion. So the first thing that you should gather from the question that is put to you is that it is a structured discussion. A lot of times there is a confusion and you get confused whether it is a simulated patient task or a structured discussion. And then you start as if you are talking to a patient. So that should not happen. Of course, in the exam, in the face-to-face exam, it is easier because you get to see just one examiner and one person sitting in the cubicle. So you know that it is a structured discussion. But even then, it's important to note what question it is. What is it? What is being assessed? So that's the first thing. Then the next thing is the domains which are being assessed. Typically in the structured discussion, you can have either 4 or 3 domains that are assessed. Now, if there is a fourth domain, that is the information gathering domain, then that means you know you should be aware that you would need to state further history, further examination, investigations, all these things. Okay, but if there are just 3 domains like patient safety, applied clinical knowledge, and communication with colleagues, there may not be a separate question as to what further information. But remember, in order to manage any patient, you would still need to gather some information from her. So, which is why you may still need to ask history. So, don't just take it for granted that there is no information gathering means you would not have to ask history. Okay, so in order to be able to manage a patient, you would need to know the background knowledge. But if it's a separate domain, remember, and you do not take history and you forget to ask, I mean, to say the history points, then you would get a straight 0 in information gathering. Okay, so that is something that you need to remember. Assess the domain, I mean, check the domains that are being assessed. Okay, the next is the body of the question, which you need to read and understand carefully as to what you are dealing with. That's important. And the last part of the question is the task. That is important for you to understand what exactly is being asked of you. Okay, like there were students who are our own students that who answered this time. They told us that it really helps to read what the task is being what task is being asked for. Like for example, there was a simulated patient task in one of the exams where there was the task mentioned. It was a simulated patient, so you have to take history, etc., and you have to ask the task says that give a differential diagnosis and formulate management. So if you forget to do that, if you forget to state a differential diagnosis, you just say that this is how you're going to manage you, then you may not get your full score, which is why it is important to understand what exactly the task says and accordingly state your facts. Okay. Now, this is a case where the consultant wants to discuss with you a 52-year-old lady who has menstrual disturbances. Now, the GP has referred her to the consultant because the GP thinks that she has perimenopausal dysfunctional uterine bleeding, and he started her on tranexamic acid, which is not helping her, and the scan report is attached. Now, the first thing that should strike you is that this is a transabdominal ultrasound which is done, which is mentioned in the question, and it shows that the uterus has a thickened endometrium. Also note that it is only mentions about the uterus, nothing else is mentioned about the state of the ovaries, etc. So first of all, you need a transvaginal examination in order to understand the situation better for the better resolution, as you mentioned rightly. So that is something that should strike you. This is a transabdominal ultrasound, which is no longer routinely done unless there is a, I mean, to assess pelvic organs. Unless the pelvic organs are big enough to go into the abdomen, then maybe it would help you. But if if the uterus is small and it's a pelvic organ, then transvaginal ultrasound is what you need to know, what you need to understand. Okay, so this is important to note. Then okay, so I think the slide is not, wait 1 second, let me just display the question. Okay, for those who have come later. So that was the question. Then, so this is a GP letter, okay, which says that there is a 52-year-old lady with perimenopausal dysfunctional bleeding, not responding to tranexamic acid. A transabdominal ultrasound is done, which shows a thickened endometrium. So this is the information that you have gathered in the 2 minutes time. And then you have to answer the questions. The first question that was asked was, what history would you like to gather? Now there is a specific question that is asked, what history? Sometimes they would ask you what further information you would like to gather from this patient. Okay, when that particular statement is made, what further information? Remember, it's not just history, it includes history, examination in the presence of chaperone with consent, and investigation. So there are three components to the question, what further information would you like to gather? When it is what further history, just mention the history. Okay, so now as far as the history is concerned, the points that you would need to know in history or need to mention in history would be, basically, first you need to know she has heavy bleeding, heavy menstrual bleeding. So you need to know what is the length of the cycle. Why is this important? Because she is close to the menopause. Remember, she's 52-year-old lady. And when the cycle length is longer than usual, followed by heavy bleeding, that means it is likely to be an ovulatory bleeding, wherein there is estrogen exposure because there is no ovulation. So there is hyperestrogenic state, which is why there is thickened endometrium, which is why you get heavy bleeding, which is unregulated because there is no progesterone, which acts as a which normally what happens in the menstrual cycle is you have estrogen in the first half of the cycle. There is ovulation. After that, there is formation of the corpus luteum. Then you have release of progesterone, which then thins out the endometrium or it cements the endometrium. Then the corpus luteum has a fixed lifespan, it gets sliced, and after that you have sudden withdrawal of hormones, after which there is lack of support to the endometrium and the entire endometrium sheds in one go. This is what happens in a normal ovulatory cycle. However, if the cycle is anovulatory, then what happens is you have, because of the anovulation, there is no corpus luteum being formed, and you have your follicles that are growing, that are secreting estrogen, that will keep building up the endometrium, and there will not be any trigger for endometrial shedding. However, the endometrium outgrows its own blood supply and there is irregular shedding of the endometrium at some point. So it is basically a breakthrough bleeding. The estrogen exposure continues. The endometrium becomes too thick to withstand further growth of the endometrium and it just sheds off in bits and pieces, which is why the bleeding is prolonged. So one important history that you need to ask in such situation is whether the cycle duration is prolonged or not, because that would give you a clue that it is an ovulatory type of bleeding associated with thickened endometrium because of hyperestrogenic state. Okay, so next is amount of bleeding. Amount of bleeding would tell you, and the duration would tell you her state. Okay, if it is chronically happening, then she is likely to have anemia and its problem. So that also you have to look into. Do not ignore that particular aspect of managing heavy menstrual bleeding. That's anemia. Okay, whether there is any intermenstrual bleeding, because that could suggest maybe a pathology of the cervix or something. Okay, then whether there is dysmenorrhea, that if there is dysmenorrhea, it may mean at this age, 52-year-old with a dysmenorrhea, it may be because of a polyp or a fibroid polyp or something like that. Endometriosis, etc., are very unlikely to start at such a late age. Okay, so it may be a fibroid that is causing congestion and dysmenorrhea. So that is why. Then other things that you routinely ask, like bladder complaints, bowel complaints, pain abdomen, lower abdomen, sexual history, postcoital bleeding, okay, medical diseases, surgeries, obstetric history, medications, important, whether she's on any HRT or herbal medications. And in a structured discussion, you need to have a kind of a structure to your history, because it automatically you would know what exactly to say in a simulated patient task. But when it comes to a structured discussion, it may be difficult to organize your thought because you're not really talking to a patient, you're talking to the examiner. So what you do is you organize your history into the history of the chief complaints. Then if it's a, say for example, if it's a pregnancy with a particular complaint, then history of pregnancy, history of the chief complaint, and rest of the history. Now rest of the history, you can have a template like medical history, surgeries, allergies, obstetric history, support, etc. All those things that you normally ask, you ask in this patient as well. Smear history is important here. Family history of cancer is important because you're dealing with something like which could possibly be a CA endometrium. Okay. And so, and it's important to justify here and there why exactly you're asking this history. Now, because she's perimenopausal, you want to know whether she's on HRT or not, whether she's taking any herbal medications, which may be estrogenic or not. So these points are important. So you can elaborate a bit on these points. Okay. So family history, because this could be possibly a cancer. So that is the reason why you're asking for family history. So then after this particular question of history in this patient, what the next thing that I told you was that the patient is having menses every 2 to 3 months, followed by heavy bleeding for 15 days. And this has been happening for 1 year. Okay. So what are you going to say? So the question was, what could be the possible diagnosis and what investigations would you like to do? So given the situation that a transabdominal scan is done and her endometrial thickness is more and she is having anovulatory bleeding, that is prolonged cycles followed by heavy bleeding, what I could think of is a possibility of, one thing is endometrial hyperplasia, okay, very likely. Second possibility, yes, there could be a possibility of endometrial cancer because endometrial thickness is 16 millimeter, which is very thick. Okay. The third possibility is that sometimes a polyp, a fibroid, or not a fibroid, or an endometrial polyp appears like thickened endometrium. Okay, so it may be an endometrial polyp as well. And the other possibility is, because of unopposed estrogen, cystic endometrial hyperplasia, which again is a type of endometrial hyperplasia with cystic spaces. So that is another possibility. So what are you going to do? What the next question was, what further investigations are you going to do? Well, yes, you would like to examine her in the presence of a chaperone with consent, but examination may not contribute much because the uterus is not very big. It's just given that it is bulky and endometrium is thickened. What is more important here is to do a transvaginal scan, complete blood count. Remember, she is having heavy menstrual bleeding for a year. So complete blood count and diagnostic hysteroscopy. These are important points. Okay. Thyroid function tests, etc. You would not do routinely for her. You would do only if she has signs and symptoms of hypothyroidism. Okay. So that is why you would do complete blood count, TVS, because you want to look at the endometrium and you want to have a better resolution. So transvaginal scan. And you also want to look at the ovaries. Don't forget the ovaries. There could be something on the ovaries as well. Okay. So you would also do a diagnostic hysteroscopy. So the next thing that was given to you is the transvaginal ultrasound report and the histopathology report. Now the transvaginal ultrasound says that uterus appears bulky, ET is 20 millimeters, and the right ovary is showing a complex cystic mass. Left ovary is normal. Okay, and the histopathology is showing atypical endometrial hyperplasia. Now, given this particular situation, that you have a thickened endometrium, anovulatory type of bleeding, hyperestrogenic type of bleeding, with a complex ovarian mass in a 52-year-old lady, does that strike anything? Can anybody tell me? Is there
Yes,
is there a possibility of something
yes,
that is going on? Yeah.
yes, ma'am. It could be granulosa cell tumor in which there
Yes.
is a increased secretion of estrogen, and we have to check the
inhibin and serum estradiol level as well.
Exactly, exactly. Okay, so it could be a granulosa cell tumor. So remember, Dr. Ginny, the thing is that you were focusing too much on the endometrial pathology that is mentioned here. Okay, you have to. This is what I mean by have a broad, open mind, and it's important to understand that it could be something that is going on the ovaries. Okay, it could be a
Yes,
malignancy also. Even otherwise, it's
yes,
a complex mass in a 52-year-old, right? So
yes,
it could be it could be something different. Hmm? So you have
yes,
to talk in terms of possibility of malignancy. Don't assume that it is just endometrial hyperplasia, and that is what. Don't try to recollect your guidelines at that point of time. How would you treat a patient who comes to you with such a picture in your own clinic? That is what you should be thinking. Okay, what all are you going to look at? If this patient had to come to you, you would definitely ask for hemoglobin. You would definitely evaluate that complex mass that is there, because then you have an open mind. But when you're answering the exam, the problem that happens with the candidates is that you tend to think of, okay, what is there in the guideline of endometrial hyperplasia? Okay, so that is the problem. Do not just fixate onto guidelines. It's important to follow the guidelines, but they are just there to guide us. What we need to look at is we need to look at the patient as a whole, have a holistic approach to managing patients. So when in this case, what you would like to do, the most important point here that you should say is that you would need an MDT management for her, because there is a possibility of cancer. There is a possibility that the ovary could be malignant. There is a possibility that she may be still harboring another malignant focus. Even if you have done a hysteroscopic biopsy, there is 43% chance of coexisting cancer in such a case. Okay, so you would ask for CA125 definitely, because there is a complex mass. Okay, at the same time, as Dr. Shaista rightly said, you need to ask for serum inhibin levels as well because of this history. Okay, not in all cases. In usually in postmenopausal complex or perimenopausal complex masses, you will just ask for CA125. But because of this typical history of unopposed estrogen bleeding and ovulatory type of bleeding, you would also ask for inhibin levels because of the ovarian mass sitting on the ovary. And then you would also calculate her RMI, okay, based on her CA125, based on the features of ultrasound. You would calculate RMI, okay. And then other things that you would do for her is that correction of anemia, lifestyle. She may be having other issues. She may be having obesity. She may be having mental health issues. Those things are also to be looked into. Then yeah, so you need to counsel her. Counseling, saying that you would counsel the patient is important even in a structured discussion, because you would do it in a simulated patient task because you're talking to the patient. You may forget to say it in a structured discussion. So that is how you lose points. Counsel her regarding the possibility of a simultaneous ovarian cancer with endometrial hyperplasia, possibility of granulosa cell tumor, which cannot always be ruled out, and tell her that the endometrial hyperplasia, which she has, atypical, is pre-malignant condition. There is a risk of 30% chance of progression to cancer and 43% chance that there may be a coexistent cancer. And the further management would depend on MDT opinion, RMI, further imaging may be required. You may require to treat her in a cancer center. Further imaging like CT scan in case of high RMI, and treating her at a cancer center. Okay. Now, in a 52-year-old, why would the lady want to conserve her uterus? Okay. Fertility is very extremely unlikely for her. Okay. I mean, it's quite unusual that a 52-year-old would like to preserve her uterus for fertility purpose. So what you need to emphasize is that you need to say that there is a possibility of this being turning into cancer. And so rather than talking about conservative measures, it's important to highlight the importance of having the uterus removed. Given the fact that there is a complex mass on the ovary, yes, you would need to have the ovaries removed as well, definitely. Um, Again, what type of surgery depends on what your evaluation says. So if your RMI comes high, etc., you would need a staging laparotomy, okay, with a complete staging procedure. If the RMI is low, you can have a laparoscopic hysterectomy along with bilateral salpingo-oophorectomy. Okay. In the meantime, you can give her progesterone suppression with iron supplementation. Okay. This is again important to say because you need to correct the anemia that she could be possibly having. Okay. So iron supplementation with progesterone suppression because progesterone is going to further put a stop to the endometrial growth that is happening. So in the meantime, you can do that. Okay. If you have to talk about conservation of the uterus, for example, the patient does not want a surgery. She's scared of a surgery. She does not want a surgery. Then you may need to talk about Mirena. Okay. That is LNGIUS. But very unlikely that a patient at that age would take the risk of cancer as against, I mean, conserving the uterus. Okay. So that is important. Counseling is important. Support. These points which you normally say in simulated patient task may be missed in structured discussion. They are counted under patient safety. So you have to say counseling, support, documentation, offering PIL. Okay. So overall, you did well in the information gathering domain and even in the investigation. So I could give you a 2 in information gathering domain. As far as communication with colleague is concerned, I would have to give you either a 0 or 1 because MDT was not mentioned, but you mentioned consultant. So I could give you a 1. So MDT is important. All right. So if you
Okay.
see, even it's that important. How you lose marks in such exam is that you may just forget to say one simple sentence that would give you a full 2 in a particular domain, like communication in colleague. If you forget the MDT point, you will just straight away lose all your marks, which is why it's important to concentrate on domains. Okay. Again, MDT is also an important point under safety. Saying these points like counseling, support, elaborating on the risk of cancer, etc., again, would be safety as an applied clinical knowledge. So, since there were points that were missing here, like need to evaluate RMI, CA 125, I would give you a 1 on applied clinical knowledge and 1 on safety. Okay, so that is how your marking scheme would be. All right, is that clear?
Okay. Yes.
Yeah. Okay. Fine. So with that, for the next station, can we have somebody volunteering, please? Anybody? Dr. Farzana, would you like to volunteer, please? Hmm. Dr. Shaista?
Yes, ma'am. I'll try.
Okay, fine. Can you see?
Yes, ma'am. Yes, I'm ready.
Okay,
Yes, ma'am.
all right. So, can you? I'll just start your time because you're uh, start your 10 minutes time. Okay. So, how will you evaluate this patient?
Yeah. So, first of all, mm, for the evaluation, I will take the history and do relevant investigations and further management according to the protocol of preterm labor. So, in history, I would like to know whether this is planned or unplanned pregnancy, and I would like to know the reason of her preterm labor. I would like to know for how long she is in labor. Is there any leaking? And if there is bleeding, so what is the amount of bleeding? Because it is significant if bleeding is significant in preterm labor. Already she's 36 weeks and she's primary gravida. So I would like to know the reason of preterm labor if patient is having any vaginal discharge, any urinary tract infection, any trauma, or inquire from the patient how frequent she is feeling the pains, duration of the pains, and how severe is the pain, and did she take any treatment, is there any leaking, any foul smelling discharge, and along with that I will inquire about the baby, um, and was she able to feel the fetal movements before the pains, and how was her ultrasound, particularly the growth of the baby, was there any evidence of IUGR, how was her blood pressure, and her sugar levels during the pregnancy, any evidence of IUGR, placenta localization, amount of liquor, and check the presentation of the baby on a scan, particularly the weight of the baby as well. And I would like to know about if patient is having any allergy, any medical or surgical comorbidities along with preterm labor. What is her blood group? Any reservation related to blood transfusion? Does she smoke? Or moreover, I would like to know her about her BMI and how is the support at home, and her mental status I will check, and after that I will check her in the presence of chaperone, um, and my nurse will check her vitals, including her pulse, blood pressure, temperature. I will do her abdominal examination, particularly for the uterine contractions. I will check the duration of contraction and severity of contraction. Check the head, whether how much head is palpable per abdomen, any evidence of a scar on the abdomen, and before doing per vaginal examination, I will rule out the placenta previa and on a scan, and do her first per speculum examination to see the amount of bleeding, and mm, and before that I will check the fetal heart sound and CTG of the patient. How is the CTG? And on perispeciculum examination, I will see if patient is in true labor pains. If I would like to know if patient is in established labor.
Uh, okay. So patient's observations are provided that the pulse is 100 per minute. Her blood pressure is 150 by 100 millimeter of mercury. On RS examination, there are basal crepitations that are noted. The saturation is 92%. Per abdominal examination, the basal tone appears increased and the fetal heart sound is at 122 per minute. Per vaginal, cervix is 4 centimeter dilated. Bleeding is noted. Station is at -2. Vertex presentation. Bag of membranes is present. What will you do now?
So I would like to know whether this is her first reading of blood pressure, the subsequent reading, because if this is first, and then I will ask my I will ask my nurse to check her blood pressure again, because I would like to rule out I would like to root out high blood pressure or preeclampsia. Okay, let me check her reports, her vitals, pulse, heart rate. Okay, and mhm. Her oxygen saturation is also low, that is 92. So I will prop up the patient and give her oxygen. And what about her temperature?
Not mentioned.
Okay, so I will ask the nurse to check her temperature, as her pulse is also high and having basal crepitations. So, is there any history of chronic lung disease or asthma or any cardiac problem with
No,
her?
no.
Right. So I will involve the there would be vaginal examination. She's 4 centimeter, bleeding noted, head at -2 station. Okay, so I would like to know about her blood investigations, including her hemoglobin, C-reactive protein, and what is her WBC count, and moreover, her ECG finding as well. There would be MDT approach, and what about her CTG?
This is the
Okay,
CTG.
all right. So baseline heart rate is also going up. That is 180. It might be because of infection or any. Okay. So I would like to know if patient is having any discharge along with bleeding. I would like to rule out the pelvic infection as well along with that. And her scan report particularly, is there any evidence of vasa previa?
No.
Weight of the baby and
No further information.
okay, so her recent scan would be done, particularly for the to rule out vasa previa, localization of placenta, and weight of the baby. And after that, I will involve the MDT, including my consultant and a neonatologist and scan doctor, a specialized midwife, a specialized nurse, and GP and GP as well. And as she is in preterm labor, I would like to I will make sure that NICU facility is available and give her a dose of steroids. Particularly, she needs 2 doses of steroids. She is 4 centimeters, so she might end up in an established labor, because at 5 centimeter we can detect it as an established labor, and heart rate is already high, that is 180. So baby is also in distress. So I will take the help of my consultant, inform all the situation related to this preterm labor, and involve the neonatologist.
How are you
As
going to deliver the baby?
all right. So first, we'll do the conservative measures. I will keep the patient in left lateral position and give her some. If there is an evidence of infection, give the patient antibiotics. And she's 4 centimeter, and she might end up in pathological CTG. So there is a need of emergency cesarean section, category 1 cesarean section. We will shoot the
Okay,
patient.
so a patient is delivered by cesarean section. Coeliac uterus was noted on table. There was a retroplacental clot of 200 gram. Baby's Apgar was 5 at 1 minute and 7 at 5 minutes. And there was bleeding noted post delivery, which was 2 liters. What would you do next?
Okay, so this is a case of abruptio placenta. So after delivery, after removal of the placenta, we'll do the active management of the third stage of labor by giving oxytocin infusion. And I would like to know her current, is she still bleeding after cesarean section or not?
Yes, 2 liters blood loss post cesarean during the cesarean. You're still on table. What would you do?
So this is an obstetrical emergency. So we will do the PPH protocol. I will call for help and make sure that patient is not Jehovah's Witness. She will need blood transfusion, and there will be after active management of third stage of labor. We will give her oxytocin infusion.
That was your
And
buzzer. Okay,
yeah.
continue.
And we'll do the pharmacological measures, including oxytocin, methergin, after ruling out of contraindications, and after that cytotec and tranexamic acid. And if still bleeding is not controlled, then the first line of surgical management would be balloon tamponade, either in the labor room or in the theater. And stepwise surgical treatment of this massive hemorrhage is B-Lynch, followed by uterine stepwise pelvic devascularization, including bilateral uterine artery ligation, bilateral ovarian artery, or internal iliac ligation. And after that, still if bleeding is not controlled, then hysterectomy would be done after after the opinion, with the help of the consultant. If first consultant is not available, then I will seek the help of second consultant. I will take the opinion of second consultant, and hysterectomy would be done earlier rather than later in order to save the life of the patient. And after that, patient would be shifted in high dependency unit for monitoring in Muse chart. There would be incident report, documentation, debriefing, and I will perform the duty of condor, and we will follow the protocol of clinical governance. And inquire about the baby, how is the baby, and baby will be shifted in early intensive care unit as early as possible because the baby's heartbeat was too high.
Okay. Okay, fine. So your timer was done.
Moreover, in investigations, there should be complete blood count, renal function test, liver function test, and coagulation profile as well, as this is a case of a placenta. And I will counsel the patient that there would be a risk of recurrence again in her, if uterus is saved, then there would be a risk of recurrence in her next pregnancy.
All right.
And in the end, leaflet, support groups, and consultation with the consultant would be provided.
Okay. Fine. So yes, so that was the task. Any reflection? Dr. Shaista, anything you would like to say?
I mean, because this is an emergency, so I think we have to give her magnesium sulfate as well. No, not before magnesium sulfate. Only steroids is okay. And yes.
Hello?
Fine. Okay.
Yeah.
Um, sorry, hello, somebody?
Yeah, I'm Shahla.
Yeah.
Yeah, I what understand she having the basal crafts and her PO2 is pulse oximetry is 92.
Hmm.
So this is also she's having pulmonary edema. She's an
Exactly.
intensive care. Yeah, she's a
Yes.
case for intensive care and should be involved the ICU physician and
Right.
yeah, mother first. Here's the mother first rather than the
Yep.
baby.
Absolutely. Absolutely right.
Yeah.
Yes. 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 Right. So yes, that was a very good input. So this patient, see, don't just go by what is given to you in the question. This is how a station can evolve. Okay. What is given to you is preterm labor. Don't fixate on preterm labor and don't try to think of things like, steroids, etc., etc. Because as you go into the station, you realize that it is not just preterm labor. Patient has high blood pressure, patient is having bleeding, patient is having low oxygen saturation, Patient is also having crepitations in the lungs, which is a critical sign, and it may mean she's having severe preeclampsia. The preterm labor could just be because of abruption, okay, and she's bleeding. Now, if there is CTG which is showing you some signs of distress, you said that, right? There is some sign of distress, like the fetus is having tachycardia. You will not wait to follow the steps of CTG as given in the guideline. Even the guidelines mentions that you would need to look at the overall picture of the patient rather than treat the CTG alone. So even if there is some or the single amber sign on the CTG, given the entire picture, you have to state that this is an emergency and the baby would be in distress. The mother is also at risk. Okay, you would need to deliver her by a cesarean section on an urgent basis. She's abruption. Okay, she's possibly abruption. Okay, it's not mentioned to you. It's not given that it is sure shot abruption, but there are findings that are suggestive of abruption. One is the bleeding. The second finding that was mentioned to you was the tone, which is increased on the abdominal findings on the abdominal examination. So this is something that you need to keep in mind. Okay, so the findings that were provided to you are these. The pulse is 100, so that is tachycardia, again possibly because of the bleeding, abruption. Blood pressure is high, there are basal crepitations, there is saturation is 92%, tone is increased, FHS is 122, which may be a dip from the tachycardia, that is baseline tachycardia that you see on CTG. There may have been a dip to 122, which becomes a deceleration if it is coming down from the baseline. Cervix is 4 centimeter dilated. There is bleeding. Station is at -2. Bag of membranes is there. So this is possibly an abruption because of the high blood pressure. You need to evaluate in terms of preeclampsia. For the abruption, you need to arrange for blood. You need to inform people. You need to inform the theatre and shift her on an urgent basis to the theatre to deliver her. At the same time, you also need to look at her RS condition. Her saturation is low. You need to provide oxygen for her, and you need to possibly consider furosemide in case you are in case you are thinking of pulmonary edema, as you rightly pointed out, Dr. Sharla, as a differential diagnosis. Okay, so these are important points that you need to keep in mind when you are, again, don't fixate on a particular, on just one thing. You know, you look at the preterm labor and your mind goes on to the NICE guidelines on preterm labor or the green top guidelines preterm labor. No, you need to look at the entire scenario that you're dealing with. Okay, and the station evolves. So when you find out more about the patient, you know that this is not preterm labor alone. This is more than preterm labor. This is more serious than just preterm labor. And even if she's preterm labor, my dear, you will not wait for, in this scenario, you'll not wait for steroids. Steroids have to be given over a period of 24 hours. You wait for 24 hours and then, you know, you need to, whatever. You can give us a stat dose of steroid, but then what's more important, you will not say steroids in this station. What's more important is you need to deliver this patient. Magnesium sulfate, if at all you are considering, is for the preeclampsia, not for neuroprotection in this case. She's 36 weeks. Okay, magnesium sulfate for the severe preeclampsia, provided all the other parameters are in place, like she's having a good urine output, and etc., etc. All those things also have to be considered, and then maybe you will consider magnesium sulfate for her, but that is for the maternal indication rather than fetal indication. Okay, so this was the CTG, which is showing baseline tachycardia, and there are dips. Even if there is, this is the baseline, okay, which you can see, that is 180 would be the baseline. So even if there is a fetal heart dropping from baseline 180 to even 140, it is still considered as a deceleration. Okay, although it is in the normal range. Okay, so that's important to remember. Then, okay. So the first question that was put to you was, given the scenario that she's having preterm labor at 36 weeks with bleeding, how will you evaluate? Here you need to keep in mind the causes of preterm labor at this stage because she's having bleeding. It could be just simple preterm labor with excessive show, possible. It could be abruption. It could be placenta previa, which is maybe undiagnosed or whatever, which is bleeding. It could be vasa previa, or it could be variceal bleeding, or it could be indeterminate bleeding. Okay, so sometimes you have vaginal varices that start bleeding, so it could be from there. But you have to keep in mind all these. Although differential diagnosis is not asked, how will you evaluate is asked, but this is what you need to keep in mind, the possibilities. So history, you have to ask about the pain, onset, duration, progress, the onset of the bleeding, when did it start, how were the fetal movements prior, whether there is associated leaking, any bladder disturbances, bowel disturbances, immediate concerns. Obstetric history, how was the pregnancy? Was it spontaneous or ART? Because ART are likely to be complicated this way. What is the course of pregnancy? Whether she had hypertension in pregnancy? Because whenever there is bleeding, we think of PET. Remember that. Abruption, one of the major causes of abruption is PET. Okay, then other medical history, surgeries, allergies, addictions, BMI, blood group, reservation, which are other history which you would anyway ask for. Examination in the presence of chaperone with consent. Observations, you would like to take her temperature. These are the things that you would like to say. What are the things that you would like to examine? Imagine this patient coming to you in labor in your hospital, in your labor ward. What are the things that you would like to look at? Do not think of what guidelines will mention, guidelines have to say. Think of the patient as a whole. Okay, then think of what the guidelines would say. Okay, first is you'll examine her in the presence of chaperone with consent. Observations would be temperature, pallor, icterus, pulse, blood pressure, RS examination, important, saturation, important, she's having bleeding, remember that, APH. Per abdomen, uterine height, presentation, uterine activity, all this you'll need to assess, whether there is any tenderness for the possibility of abruption, and the fetal heart sounds. Okay, you may have to do a vaginal examination considering that she's maybe in active labor, but before that you need to look at her records and check if there is any placenta previa mentioned there, because she could be bleeding because of the placenta previa. So if there is no placenta previa, you do a per vaginal examination and see what is the status per speculum per vaginal examination. CTG, most important because she's having bleeding. Okay, so after that, the observations were provided to you, then what you're going to do. Okay, so yeah, right. So once the observations are provided to you, hypertension is mentioned 150, 100 millimeters of mercury is the blood pressure. So you would like to ask for a few more questions here, whether this is a new onset hypertension or did she have hypertension to begin with? Was she on any antihypertensives? Does she have any symptoms of severe preeclampsia? Okay, always your structure should be history, examination, investigation, management. That is how it should be. So when what further, you know that the situation is evolving, you ask what are further steps. Given this information, this is what I want to know, this is what I want to do or want to investigate, and this is how I'm going to manage. That's how your thought process should be. So onset, duration, antihypertensive management, headache, history of decreased output, epigastric pain, blurring of vision, fits, and all those things which are severe preeclampsia history. Investigations you would like to do: urine proteins, renal function test, liver function test, complete blood count, and your coagulation profile. And you would I also like to ask for blood for cross matching. Okay, so these are the investigations, blood investigations that you would like to send for her. There is some disturbance. Can everybody please mute yourselves? Some disturbance that are there. Okay, fine. So investigations: urine protein, renal function test, liver function test, complete blood count, coagulation profile, and blood for cross matching, which is very important because she's having bleeding. Management would be antihypertensives. You would give her the immediate management of any hypertensive crisis or high blood pressure, as per NICE guidelines, now you can use your guidelines, is tab labetalol 200 milligram stat if she's not allergic and she's not asthmatic. Okay. If she doesn't respond to that 200 milligram, you can repeat after half an hour. If no, then you resort to IV. Okay, so this is what you need to do. She has possibility of pulmonary edema. You can get an urgent X-ray if that is possible. If that's not possible, then you can consider giving her furosemide because you want to save the mother from pulmonary edema. Okay, so that is another important thing that you can say. Yeah, magnesium sulfate is also important to mention if there are severe symptoms and severe preeclampsia as a prophylactic measure for eclampsia. So prophylactic magnesium sulfate can be considered here as well. CTG is showing baseline tachycardia, so there is possibility of abruption with fetal distress. That is what you need to gather from this station. So you can, in order to confirm, you can just urgently organize a bedside ultrasound if that can show you any retroplacental clots. If not, it is important to go clinically by clinical diagnosis. Consider that this has abruption, and your management should be in on terms of abruption. So multidisciplinary team, consultant OBG, anesthesia, ICU bed to be arranged, blood bank to be involved, hematologist to be arranged to be involved. Blood to be arranged, as I already mentioned. Counsel her, take her consent, inform theatre and shift for a cesarean section. Inform anesthetist about the possibility of massive hemorrhage so that you can plan about the type of anesthesia. When there is a possibility of massive hemorrhage, the anesthesia that is preferred would be general anesthesia as compared with regional anesthesia, although regional may be better suited for an obstetric patient, but in this case, you may have to consider general anesthesia. Okay. Then, okay. So then next thing that was told to you was that she's on table and you notice that there is covariate uterus and there is retroplacental clot and there is massive bleeding, which is 2 liters. So what would you do next? You would activate the MOH protocol. That's important to say. And you would start the steps of communication, resuscitation, investigations, and monitoring and arrest all simultaneously. This is something that you can very well say in any obstetric emergency. The 4 steps have to be remembered and they have to be, and you have to say that you would you would start these steps, 4 steps simultaneously. These are mentioned in the PPH guidelines, screen top guidelines. Okay, so who would you communicate with? Remember the scenario. You are in the theater. Now, assuming that the consultant is already on table because this is a serious emergency, so consultant is likely to be there. The other people that you would inform would be the anesthesia consultant, the circulating nurse in the OT, so as to communicate with the personnel outside OT, blood bank, hematologist, patient's relatives have to be counseled. If the patient is awake, then you may need to talk to her as well. Porters, scribers to be arranged. Cell saver technician may have to be informed because this is likely to result in massive hemorrhage if all those facilities are available. Resuscitation depends on how many IV cannula she has. You pass 2 wide bow IV cannulae. She's likely to have them anyway. Crystalloids followed by colloids till your blood arrives. X cells, FFPs, cryoprecipitate, platelet concentrates would have to be asked for because this is major obstetric hemorrhage in the face of abruption. And when there is a major obstetric hemorrhage in the face of abruption, you know that there is coagulopathy that sets in earlier as compared with PPH otherwise. Okay. Oxygen, keep the patient warm. These are things that we forget and we need to mention them. Okay. Arrest would be uterine massage, aortic compression. Since you're on table, remember there are things that you can take advantage of. You can do an aortic compression if there's active bleeding. Okay, your assistant can help you with that. Oxytocin, carbetocin, although the guidelines does not mention carbetocin for treatment, it mentions for prophylaxis may be considered, but you can make a mention. Tranexamic acid, misoprostol, carboprostol, and Ergometrin would not be mentioned here because she's hypertensive. But remember, if there is atony which does not respond, then you may still have to use it, but it is better to avoid saying ergometrin for hypertensive patients. Surgical steps may have to be resorted to, like your brace sutures, peelings, Cho sutures, etc. Systemic devascularization may have to be considered. Uterine arteries, bilateral, unilateral, internal iliac arteries, ligation, selective arterial occlusion or by embolization, interventional radiology, and hysterectomy, the last resort. At the same time, you may have to repeat investigations because there is ongoing bleeding. So complete blood count, renal function test, liver function test, coagulation profile, and at the same time, somebody has to monitor her observations on a Meows chart. So these are the steps you need to mention when there is PPH. And when you stick to these 4 components, communication, investigations, resuscitation, monitoring, and arrest of bleeding, you will not forget points. Okay, so you classify your answer, or I mean you organize your answer according to these 4 broad categories. Okay, so after that, I didn't ask you about the post. It was not a part of the question, but if so these are the doses which in a structured discussion are asked. Okay, and in this exam they were specifically asking doses of these important drugs used in obstetrics. So please make sure that you know your doses well, because it is important for an obstetrician to know the doses of your oxytocics. Okay, these are the various oxytocic agents. Along with that, you can also add tranexamic acid, which is not an oxytocic, but it is used as an antifibrinolytic to prevent bleeding. Okay, which can be given in the dose mentioned. So these are the various oxytocic agents that you would need to know the doses of. Okay, so just to elaborate a bit on the fluid therapy, first you start crystalloids, 2 liters, isotonic, followed by colloids, provided the blood has not yet arrived. If the blood arrives, you start blood. That's the dictum. Then if the immediate transfusion is indicated and you do not have a cross-match sample, then you can have O negative, rhesus negative, K negative red cell units can be transfused. Fresh frozen plasma and cryoprecipitate may have to be considered. Fresh frozen plasma, if your prothrombin time or APTT is prolonged and the hemorrhage is ongoing, 12 to 15 ml per kg. And if the hemorrhage continues, your APTT-PT is not available, you have already transfused 4 units of RBCs, then you need to transfuse 4 FFPs. This is something that you should remember, because they can ask you specific questions. Okay. Platelet counts, platelet concentrates would have to be transfused the moment it dips below 75,000. So the moment your platelet count dips below 75,000, you start your platelet transfusion. Remember, you have to maintain them above 50, but you start transfusion the moment it dips below 75,000. As per the guideline, you maintain the platelet levels above 50. So when they go below 75, they can rapidly fall. So you start your transfusion when they go below 75,000. Okay, so that's important to remember. Cryoprecipitate if your fibrinogen falls below 2 gram per liter. So this is something that you would need to understand. Postpartum, I had not asked you the question, but if it was asked, then yes, postpartum post-op, sorry, yeah, post-op. This thing she would need to be monitored under ICU and or HDU setting. Continuous monitoring on a Meows chart. Urine output has to be monitored. Keep her warm. Antibiotics, DVT prophylaxis, and all the clinical governance measures. Debrief, documentation, DETICS, duty of candor. Another point that you may have to include if it mentions she has Rh negative blood group is about NTD, which can happen in such situations, such stations. They may just add that she's having negative blood group. So you need to mention about NTD. If you don't, you will lose on your patient safety. Okay. This particular picture of the Meows chart, I just added to tell you that whenever they give you Meows in the exam, they may give you Meows chart to read. Okay. What you need to remember is that you need to look at the red or the orange, wherever there is red areas. and see if any of the observations are falling in those areas. So you know that those are the significant features. Don't try to read the entire Meows chart. See if it is falling in the red. Why is that Meows chart why is it being used in the first place? Because you can just look at it and see if any parameter is falling in the red zone and then pick it up. Okay, so that is how you save your time in the exam when you're given a Meows chart to read, and you just have to look at which is amber, which is red, which is white. Okay, so if it is white, you ignore it, you take it for granted, it's normal, white zone. Then if it is in the red zone, you know that this is serious. Okay, so that is what you need to look at. Okay, it's very easy to interpret a Meows chart when you know that red means danger. Okay, so that's the thing about the Meows. And okay, so this was a bit of PPH protocol that was mentioned in strategy. Okay, so yeah, so this is about it. So what I need to emphasize here is that this is a case of abruption. This is a case of severe preeclampsia. You need to focus your mind on the serious problems that the patient has. Preterm labor is not that she's at 36 weeks. It's not going to affect the baby much, but the preeclampsia abruption can result in death of the baby and can result in complications, serious complications for the mother. So which is why you need to address those. You need to identify that this is a serious condition that the mother is having. All right, is that clear?
Dr. Ankita, I have one question, please.
Yes.
So in such case she is severe preeclampsia with abruptia placenta, and the patient unstable and need time to stabilize the patient. Why will not go for artificial rupture of membrane to reduce the tension inside the uterus while stabilize the patient? Because if we shift her to the GA, as you mentioned, GA is better than it may be. Then refuse to give any local because of hemodynamic unstable and maybe bleeding disorder. So GA and surgical incision will increase the risk of PPH. So mother is a priority here. Why not go for to rupture there?
Yeah, you can go for artificial rupture of membranes, but the thing is, she's 36 weeks, right? And she's having you are having a CTG which is not very good here. Okay. Yes, of course you need to evaluate her. In the meantime, you can do a artificial rupture of membranes. You need to evaluate her for coagulopathy. You need to correct it, but you don't wait. Okay. In such a situation, you shift the patient, you give her the FFPs, you give her the cryoprecipitate, and shift her, correct her coagulation problem that she's having, and shift her to the theater, irrespective of whether you do a artificial rupture of membranes or not. But the thing is, you're not going to wait for such a patient to worsen. It may not be safe for you to say that you would wait for her for a vaginal delivery, because vaginal delivery is going to have less of a problem. Remember, if you wait longer, vaginal delivery is going to take time. She can have problems, baby can have problems, her saturation is dropping. So you need to deliver this patient urgently. You cannot wait for her, which is why you need to shift her to the theater. Okay, that is important. Although yes, you are right, absolutely, that she may be in coagulation. She may be having coagulopathy already, definitely, no doubt. But you need to correct the coagulopathy immediate basis and shift her. You need to ask for blood transfusion, you need to ask for FFP transfusion, and have a lower threshold for transfusion of platelet concentrates and your cryoprecipitate and FFPs, and shift her to the theater, because it's abruption. If it was any other PPH, then you can afford to wait for your coagulation profile to come and then assess her and then transfusion her. But when there is abruption, you would start the transfusion and shift her to the theater.
Yeah, we can. I save the mother. Or the baby maybe with rupture of membrane will get rapid progress. Could be in abruption we get rapid progress even if it's preterm.
Yes, you can get a rapid progress, but it's 4 centimeter dilated. Even if you do get a rapid progress of labor, even if she say dilates to fully dilated, it'll at least take 2 hours for you to deliver this patient, isn't it? So for you as an ST5, safest way out is to say that this is an emergency. We need to save the mother, and at the same time, you can save the baby as well, right? So you need to shift her to the theater for delivery. Okay, so that would be the safest way for an ST5. It is okay for a consultant to decide that no, I'm going to wait for this patient. Okay, but I mean that is very unlikely given the entire scenario that she's having respiratory distress, she's having high blood pressure. Okay, if the mother was stable otherwise and there were no other problems, waiting makes sense. But if the mother is unstable, okay, saturation has dropped. It does not really make sense to wait for with her, because even if you allow a vaginal delivery is best for a patient who is having DIC, no doubt, who's having coagulopathy, no doubt, absolutely. But who's just 4 centimeters, she will at least take minimum 2 hours. Even if she goes in precipitate labor, she will at least take 2 hours to dilate and deliver. Okay, so which is why, and she's primary gravid patient, she's not a multi. So which is why it's important to say that I would shift to the theater. Okay, because then you have your anesthetist managing her pulmonary edema, etc., etc., and you are the one who's basically helping her by doing the delivery. Of course, your consultant would be around.
Yeah, we need consultant anesthetist and consultant.
Yes. Yes.
Yeah. Situation. Okay,
Yes.
thanks.
All right. Any other question? All right. So I hope that helped you all. With that, we'll wind up. So this is just an idea that I wanted to give you about how a station can evolve, how such, you need to look at various aspects of patient management rather than just focusing on what is mentioned to you in the station. You need to have an open mind. Imagine yourself. That will help you, because all of you are practicing obstetricians, I believe. So you have to imagine yourself in that situation, managing that particular patient, and accordingly act, and accordingly, state your points. All right. Okay. So good night, everyone.
Thank you so much, ma'am. Very nice session.
Thank you, Doctor.
Thank you, ma'am.